Good morning, everybody, and welcome to the Friday Informatics PowerTalks series. Happy Friday, and I'm very happy to introduce today's speaker. I've known him for a very long time. Richard, everybody calls him Dick Schreiber, and he was formerly Associate Chief Medical Informatics Officer at Penn State Health Holy Spirit Medical Center at Penn State Health, and recently retired. Congratulations, very, very recently. As in his prior role, opened up hospitals, transitioned hospitals with multiple practices into the same EHR system, enterprise-wide Cerner Millennium implementation, which I also have an interest in this area, so I know that it's challenging. He has extensive experience in informatics in hospital and in outpatient settings. And it just has touched every part of informatics, practicing EHRs, transitions, burden analysis, reduction, clinical decision support, technology adoption, optimization, and of course, education, meaningful use, interoperability. I know he's also been involved with, the board certification and preparing the exam for physicians taking the exam. He's graduated from University of Rochester Associated Hospitals residency. He was in private practice for 25 years, and his primary hospital was acquired by Geisinger and then was owned by Penn State Health. So after 38 years of an internist and hospital medicine, informatics, education research, as he says, it's time to take down the shingle. And I'm sure that we're still going to see him. He's still going to be doing lots of things, just in a different new career adventure. The title of this talk is Challenges, Opportunities, and Best Practices for Clinical Decision Support, Governance, and Implementation.
Amy, thank you for that kind introduction. Everything you said is true, and it's been a fun trip. And now it's time to move on to something else and let someone else take the show here. In all of those sales and transitions and different electronic records and practice environments and so on, I've had the opportunity to observe how different organizations handle clinical decision support, which I'm just going to use CDS as the abbreviation from here on out. It's a lot easier to say. And in particular, how it's governed. That perspective has included my own hospital that I was working in, the primary hospital I was working in, which was just its own institution, a community hospital not owned by anybody else but the hospital itself, and then bought by one and then another large organization. So I've had the opportunity to make lots of observations on how governance works. And that's what I'm going to focus on in the next 30 odd minutes or so. So we always have to do disclosures, of course. Proud and just sort of patting myself on the back here. A couple of days ago, a chapter that my colleague and I, John McGreevy, some of you may know him at the University of Pennsylvania, wrote a chapter for clinical decision support and beyond entitled Governance and Implementation. So a lot of the materials that I have in this talk, I've derived from that chapter. And as a disclosure, I'm supposed to get a honorarium for having written the chapter. Haven't gotten it yet, but the book's been published. All right. So these are the main points I'm going to make. I'm going to talk about how, sorry about that. I don't know why that's popping up. I'm going to make the main point that governance really is the confluence of many different features, and I'll go into each one of them as we move along. If you have appropriate governance, then you can have systematic and transparent decision-making. By decision-making, I don't mean CDS, clinical decision-making. I mean the decision-making regarding what to include in your clinical decision support. The governance is hard, and there are a lot of challenges, and I will list a whole bunch of them. I will also state that governance will evolve as the organization matures, even if that evolution is not clear from the beginning, or even clear while it's happening. And I'm going to state that we must ensure that ongoing review and evaluation of up-and-coming technologies is an important role of clinical decision support governance. So what did governance look like in the old days? I'm not sure if you're seeing this, but it's hiding the title here. So I'll just tell you what I'm talking about here. Well, certainly small organizations, when they're encountering a new electronic record, they don't really have the wherewithal to develop CDS. So they might say, well, let's just go with what the vendor tells us. Then there's a group of people who say, we got this. Hey, we know what we're doing. We've got our own homegrown EHR. We're going to develop our own CDS. We're going to make it proprietary. We've got it. We know exactly what we're doing. We're the boss. Then there's a group that just gets squirreled or deflected or distracted by every bright, shiny object. And I love all of those things. CDS is great. It's the best thing since sliced bread. Let's just build all of it. And then there's a group that just wants to get by. For those of you old enough to remember meaningful use back the last decade, basically you got money for doing what the government says is the minimum to achieve meaningful use of your electronic record. The money is important, especially if you don't have the personnel or the time. So you just went ahead and did the, I think the number was a dozen or 14 clinical decision support elements that were required. And then there's a group that just throws up its hands and has no idea what to do, has no governance in place, and that's very distressful, very anxiety provoking. So how did all this work? Did it work out for us? I think we were extraordinarily enthusiastic about clinical decision support. It was the best thing since sliced bread, and it was going to create all kinds of improved clinical outcomes. And it was going to keep us from making egregious errors and all that. But it really didn't work out that way, did it? Everybody complains about over alerting and the consequent burden of alert fatigue. That increased clinician burden is very much an element of clinician burnout, which is a major, major problem right now, and topic for an entirely discrete power talk, costing us somewhere between $4 and $5 billion a year, but I digress. Has it improved clinical outcomes? Very difficult to prove. The most recent meta-analysis and review that I came across, which was approximately 10 months or a year ago, basically said that overall, any study that shows improved clinical outcomes improves outcomes by approximately 5.3%. Now that sounds like nothing, but think of a clinical situation. I don't know how many of the participants on this call, on this Zoom today are actually clinicians, but in the field of congestive heart failure, a very debilitating illness that untreated is fatal within 5 years or less. The studies since the 1970s and 80s, each one showed approximately a 5 to 10% improvement in survival, which again, doesn't sound like much, but now between beta blockers, proper diuretic therapy, ACE inhibitors, a bunch of other drugs, the mortality has decreased by somewhere between 60 and 70% over 5 years. In other words, survival has improved by about that much, and it's getting better and better each day with every new therapy. So I maintain, and I don't have any empiric evidence for this, but I maintain that every study that can show a 5 or so % increase in clinical improvement in clinical outcomes with clinical decision support is getting us in the right direction. And I think that's what we have to keep in mind, because CDS, one alert at a time, is not the way to analyze this topic. The way to look at it is the totality of the issue. So has CDS improved clinical outcomes? Maybe, but that's also a topic for another time. The unfortunate part of over alerting and alert fatigue is that it means a lot of rework for all of the alerts and banners and order sets and everything else. So it's a tremendous amount of work. So what's good governance?
Sorry to interrupt, just a quick note on the previous, what you were just discussing about the background. There was a request for a reference, a list of references for these that you mentioned that show these outcomes. So you could also always send that later on, but just someone had asked for references.
Sure, I will supply that to you, Amy, and then you can send it out to the group.
Thanks.
Sure. All right, so what does good governance entail? Well, all of these things: accountability, transparency, responsiveness. It must be equitable and inclusive, effective and efficient. Of course, it must follow the rules of law, regulations, meaningful use, the whole bit. Participatory, I'll get into in more detail in a minute. And consensus-oriented, I would debate. Consensus is one method of good governance, and the purpose of today's talk is to talk about some of the other opportunities. However, good governance often looks like this, or I should say governance turns into this. And that's one reason it evolves over time. You make one stab, it doesn't work, you move on to another. So this is a chart that I think is a simplification. This diagram shows that the confluence of leadership and management, accountability and communication leads to that optimal space colored gray in the middle of this diagram. Leadership, of course, means those at the top who are guiding the mission of the organization. They are setting the tone and they are hiring and firing. Management actually gets the job done. Those are the people in the trenches who actually do the work that leadership directs. Communication is very, very difficult. What's the phrase? In an organization, if you announce something 7 times, half the people will have heard it once. Horseman's Law, I believe that is. So even if you are a good communicator, you have to repeat the message often. Accountability means a lot of things. It includes acknowledging when you make a mistake. That's the most obvious example of accountability, but it also means who is in charge, who is the owner, for example, of an order set, who do you turn to when you need to make a change. I do have some references that I've included at the bottom of the slide. In this case, this is a diagram that's directly out of the chapter that I mentioned earlier. So when you get the slides, you'll have some of the references. This is one governance structure that may or may not work. It's a rough outline. I've toyed with this diagram now for about 15 years, and I still don't feel like I have it exactly right. But basically, it tries to start with leadership at the top and, if you will, management and the ones that get the job done in multiple boxes below. On the left-hand side, with the text colored yellow, I identify as the primary, not the sole, but the primary role of informatics. And you can call these committees, the ambulatory inpatient orders and order sets, and so on. Different places have different committees with different jurisdictions. It doesn't really matter what you call them and what their duties are, but I have always found it helpful, and the organizations I've worked with have found it helpful to divvy up the work so that people are involved in the processes to the best of their abilities. Now, I think it's also important that you have communication up and down this ladder of responsibility, meaning that if you have an inpatient hospitalist who is an expert in orders and order sets and medication reconciliation, for example, the ideas and knowledge base of that hospitalist applies not just to the inpatient clinical decision support, but to, as I just mentioned, orders and order sets, and maybe even to clinical documentation, and may have ideas that would help the ambulatory physicians. So feeding above and below your level is important for communication, idea transmission, and the avoidance of silos. Ultimately, all of clinical decision support and informatics in general, I think, should report up to the medical executive committee. Why the med exec and not, say, the CIO or the CEO or the CAO or whatever C-suite you're talking about? In my view, clinical physician informatics is a medical staff responsibility. So this is a major message that I'm trying to convey. It is the duty of the medical staff to guide its own informatics. It's not the administration, in my view. It's not, for the case of physicians, it's not the nurses, and for the nurses, it's not the physicians, and so on, although there's much overlap. I think ultimately the responsibility for what's included in the electronic record and for the various other applications that communicate with the EHR, and I'll get into that in a second, is the responsibility of the medical executive committee. So in the organizations that I've been in, the chief medical informatics officer reports directly to MedExec and is an ex officio member. And that, for me, has worked. Now, What has the medical executive committee told me when I've proposed something? They say, you go ahead and do it. You know what you're talking about, and proceed. Well, that's nice. That's a pat on the back. But first of all, it's not 100% of the time. And secondly, it means that they know what I'm doing. And that communication is all important. Then I mentioned, the CMIO. I'll go into this in a slide or two, that the CMIO, I think, is the focus of all of these informatics efforts. I'm not sure there's much debate about that, but believe it or not, there's some organizations where the CMIO does not have any influence on the rest of IT, which I think is a mistake. Even though that may not be one's personal expertise. For example, what do I know about interfaces in HL7? Not much, but I know what FHIR is, FHIR. If anyone doesn't know what that is, we can go into it. But that's a key interface tool that is very important in informatics. So those are the principles that I would say are important in any governance structure, no matter where you have the lines connect. So who's involved in this governance? Well, I mentioned physicians and I mentioned nurses. Obviously, they're key. I would also include, of course, pharmacists, because that triumvirate, physicians, nurses, and pharmacists, first of all, is required by the conditions of participation for the Centers for Medicare and Medicaid Services, CMS. So that's a given. I include under the physicians as well, advanced practitioners, because in many institutions, especially academic medical centers, the APs, the physician assistants and the CRNPs and CRNAs, they do a ton of the work, if not the majority. I know that, for example, at my hospital, the PAs on the orthopedic service probably do 95% or more of the orders. The admission histories and physicals, which the attendings, of course, have to co-sign, they do the bulk of the work. And so they know exactly what's going on inside the EHR. They need to be represented. And I feel that if they're not involved in governance, you're not really hitting the population that does the work. So that's clinicians. Informaticists overlap there. And again, I've highlighted physician, nursing, and pharmacy are the minimum required. Don't forget about your allied health professionals, physical and occupational therapists, speech therapists, respiratory therapists, dietitians or nutritionists, depending on what you name them at your institution. These are all important people in the governance of clinical decision support. Obviously, IT and obviously administration have to be involved. And this is the origin, these four areas, where CMIOs were first described way back in what I call CMIO version 1, namely communicators and the translators between the different organizations. When I first became a CMIO in 2005, I thought my job was basically to be the interpreter between clinicians, IT, and administration. That was true, and it's still true. It's no longer the focus of being a CMIO. In my own schema, in my own head, I have gotten us up to CMIO version 5. But again, that's a topic for another talk. So these are the bare minimum people that are involved in governance and need to be represented. But that presents a problem. Why? How? Well, can you find the right people? Let me tell you a quick story. One of the things that I tried to do very early on, 2005, 2006, I learned very early that it is important to get the naysayers in on the conversation. Why? Because they're very critical. They may be very nihilistic or negative, but they also can tell you what's not going well. So I was in the physician lounge one day trying to recruit physicians to be on my physician advisory committee. And a person I knew very well, who was a naysayer, came into the office there. And I asked him if he wanted to be on the physician advisory committee. And he turned to the door, put his hand on the handle, opened the door halfway, didn't even look at me and said, "No way, never," and walked out the door. So getting the right people is very difficult. Analysts, IT analysts, it is very hard to get knowledgeable people to certain institutions. My hospital is in the environs of Harrisburg, Pennsylvania, which is about halfway between Pittsburgh and Philadelphia. Well, you've got really smart 20 and 30 somethings, probably a lot of the people in this audience right now, they may be more inclined to go to places like San Francisco, Los Angeles, Chicago, Denver, Boston, Birmingham, Alabama, for all I know. It's very hard to get people, quality people, and enough of them to a place like Harrisburg, Pennsylvania. So that's another challenge. Everybody talks about interoperability, and you all know what I mean. I trust you know what I mean about interoperability of sharing patient records between EHRs. I'm also talking about interoperability within an organization. Large organizations have 200, 300, or 400 different applications that all apply to health information technology. I'm not just talking about the EHR modalities and radiology and laboratory. I mean, for example, the application that you may have in your gastroenterology laboratory to do esophageal manometry. Well, you want to have that information incorporated into the EHR, so it has to be interoperable, preferably interfaced, but we can't always have that, with your electronic record. And developing those connections is extremely difficult, especially when they were not built to do that. I think sufficient Wi-Fi and high-speed internet is kind of obvious, but when you have a building, in my case, that was built in 1963 with a lot of concrete and cinder block, Wi-Fi is a big challenge. Physicians, very enthusiastic for 5 minutes. I'm a physician, I can say this about my group. Very enthusiastic and devoted for 5 minutes. And then, the second meeting and the third meeting, attendance dwindles. It's not just about time, it's about reimbursement. I'll mention that in a minute too. Depth and breadth of experience, I think, is kind of obvious. When I first became a CMIO, I didn't know very much at all. I've learned a lot over the years, but early on, experience counts. And then I mentioned communication before and how difficult that is. So that's a challenge. So what's the difference between bad governance and good governance? Well, I've already mentioned what I think good governance should look like. That's on the right-hand side. But the bandit on the left, inefficiencies, red tape, maladministration, I'm not sure I know even exactly what that means. Corruption, that's hopefully not going on in healthcare, but who knows. Secrecy is more, I would put in the realm of silos. So let's get into a little bit more details. I mentioned that physicians are hard to recruit and retain. Do you compensate them? Who is accountable? Does the chair of the Department of Neurosurgery want to own neurosurgeons' order sets? Most of the time, I think they do. Certainly my colleagues all over the years have, but do they really commit to it? And when you want to make a change, do they respond promptly? What if their favorite drug is no longer available or is on back order? Are they going to be happy with approving a substitute? Pharmacy helps us out tremendously in that regard, but does the owner really respond? Keep in mind also that CDS is a clinical endeavor. It's not technical. It's not IT driven. If IT owns CDS or is perceived to own it, then clinicians will not be engaged. If clinicians own it and are responsible and therefore accountable for it, then they must be engaged. But will they be? That's one of the challenges. I don't think CDS should be vendor driven, although often it is. Remember my first slide of we don't know what we're doing, let's just let the vendor do it. I'll try to remember to include this reference too. Melissa Biceri, who is a sociotechnical researcher in Australia, a very good author, some of you may be familiar with her work, just published literally 2 days ago, I saw the article, interviewed, I think it was 18 or 20 informatics experts in Australia about whether vendor-derived CDS is really evidence-based and should CDS be evidence-based at all. Her conclusion was basically no, that a lot of CDS is not evidence-based. If it is, it's coming from the vendor and not from the clinicians themselves. So I'll try to include that reference. Now, do I agree with that? I think it's true sometimes, but a lot of locally derived clinical decision support is evidence-based, and at least in the institution in which it is created. All right, think back to this schema here for 1 second. These, not sure if you'll see my cursor. these groups down here towards the bottom, ambulatory, inpatient, order sets, and so on, should the governance allow these groups, these committees, to make its own autonomous decisions or not? For the or not, would something that comes up in, let's say, the order set group have to go up through the ladder and all the way up to the medical executive committee? Well, I maintain that it's a mixture of both. Some decisions I think can be made autonomously. Some are interdependent, and some do need to go up to the top. So let me give you a couple of quick examples. Pharmacy says that a certain drug is not available, so they need to substitute in an order set a pretty equivalent drug where there's very little debate. Does that need to go up to higher levels of CDS governance? I think not. I think pharmacy should advise the order set group that that's what's going on. The order set group should say, go for it, fix it as fast as you can, and just do it. It's obvious, it's not going to be debatable. Yes, the neurosurgeon is going to have to agree that that drug is not available, and so they're going to have to accept the alternative. Some of it's interdependent. For example, if you do substitute a drug on an order set, it's probably, or it might change the clinical decision support surrounding, say, antibiotics for sepsis or something pretty involved. So I would maintain that the order set group would have to get together with the CDS group and make sure that it's all compatible. Does that have to go up to a higher level? Probably not. Only those circumstances where something is involving many groups, many of the committees, and also perhaps many departments, should that rise to the level of the medical executive committee. An example of that would be correction dosing of insulin for blood sugars. In other words, let's say you wanted to develop a protocol so that the nurses could change the intensity of insulin coverage based on a patient's 24-hour record of blood sugars. We have that protocol at Holy Spirit Hospital. In other words, based on specific numbers, the nurse can raise the intensity of the sliding scale, it used to be called sliding scale, correction scale, or lower it based on the patient's blood sugars without having to call the attending physician and get approval. Now, it's a protocol, so the attending is going to have to review it and sign it, but not at the time that the nurse enters the order. That, I think, should go to medical exec. Why? Because it involves basically every single hospital patient, and it involves multiple departments, not just the hospitalists or endocrinologists, but it'll impact surgical patients. And keep in mind, for example, that you don't want overly tight control in your cardiovascular post-op patients. So that should be a decision reached at the highest levels of the clinical decision support super governance committee and or the medical executive committee. So there are more challenges. I mentioned before that good governance should be consensus driven. Well, that's one way to do it. Holy Spirit Hospital, when it was all on its own, very much has a culture of consensus. Everyone needs to be involved. Everybody gets a voice, and you make a decision based on the consensus of the group at large. That's great. People are happy. People feel involved, responsible, and accountable, and you get the job done, but it takes time. That's not really workable when you've got a large organization with 8 hospitals dispersed over 250 miles. I won't specify exactly the name of that organization in central and northeastern Pennsylvania. Oh, you can probably figure it out. So there's a certain amount of hierarchical structure that may work better. Some people call that top down, which has a bad connotation, and sometimes that bad connotation is earned, because if decisions are made from the top without involvement of the folks at the lower levels and at the individual hospitals, it could be detrimental. So you have to make compromises and you have to mix and match what works for you. Cultural considerations are important. Obvious example here is that Holy Spirit Hospital is run by the Sisters of Christian Charity, a Catholic hospital. There are certain rules. that must be followed. And that may be different from, say, an inner city public hospital. So that has a lot to do with your governance. Available personnel, I've already dwelled on. Financial resources seems kind of obvious. If you can afford it, you can do it. If you're not wealthy, you've got a problem. How do you allocate your budget and your funds? And the size of the organization I alluded to just a minute ago. How many hospitals, how dispersed are they? Maybe they're in different states, in which case you've got state laws to consider and so on. Very challenging environment for governance. Then there's the CDS priorities. In other words, how do you deal with what everybody wants to do? Well, at the bottom of this pyramid are the true break fixes. There's just an obvious error. You've got to fix that, obviously. I mentioned formulary changes. If you don't have the drug, you can't allow it to be ordered. Patient safety issues, for example, your allergy alerting isn't working. Well, you better fix that because that could be immediately life-threatening. We usually rank laws and regulations as the next priority. Obviously, if you get defunded, if you lose your Medicare certification, you're in a peck of trouble. Then John McGreevy and I define levels 3, 4, and 5 as high priority and mission critical versus mission sensitive. And then lastly, the nice to haves. Now, unlike this pyramid, the numbers of requests in these categories is exactly the reverse. In other words, the nice to haves would occupy this entire screen in most organizations. The true break fixes, fortunately, are usually few and far between, 1 or 2 here and there, and sometimes there are none in the queue because you've fixed them. So invert this pyramid in terms of the numbers. That's a challenge as well. All right, so in the article referenced on the bottom of the slide, Reducing Alert Burden in EHRs, John McGreevy and others proposed this strategy. It's hidden on my screen, the creator strategy. You can tell by the bolded letters. And I'm not going to read it to you, but basically, how do you prioritize CDS requests? Well, you have to consider all of these things. Is it part of the strategy? Is it timely? Is it something that you can actually evaluate? Is it actionable? Now, actionable, in my view, means having a button on the alert or somewhere, however you're presenting the CDS, where the clinician can take the action that you're recommending. If the alert simply says, hey, don't do this, this is a mistake, the question the good clinician will have is, well, what is the right thing to do? And let me do it right now, right here, without further interruption. It's amazing to me how many alerts and so on are not actionable. It's amazing to me how many vendor products don't make this easy. I think this is first and foremost a vendor responsibility to make it always available, and then for the local organization to effect that change, to create the change. It's amazing in my experience how infrequently this is possible. By transparency, we're talking about avoiding biases. This has become a hot button item in the last year or two. Our paper was written published 3 years ago now. And I'm happy to say that we thought of this transparency issue in terms of avoiding biases, especially in automated processes, machine learning, and so on. Overridable, well, sometimes the machine isn't as smart as we think it is, and evidence-based. But there are a couple of socio-technical impediments as well to achieving good governance. I mentioned the availability of professionals and analysts. Some markets can't attract personnel. I mentioned that before. I've published in association particularly with Adam Wright. I'm sure most of you have heard of him. CDS can make errors and have anomalies for very bizarre reasons. And there's a whole literature on this now about how CDS can actually create errors rather than fix them. I'll try, Amy, to remember to include some of those references as well. Money matters. Unrealistic allotments, meaning your budget isn't assessed properly. Leadership turnover is a problem. In most businesses, the CEO, I'm not talking about healthcare, but it applies to healthcare as well. The CEO turns over an average of every 5.5 years. Well, that's just when they're starting to get going. And the same thing is true in medical systems. The president of most medical staffs is a 1 or a 2-year term, rarely appointed or elected to a second term. So that kind of turnover loses institutional knowledge. And then, there's all this regulatory change that's happening minute by minute, hour by hour. 21st Century Cures Act is an example. The ACA I'll mention, or the AUC, which I'll mention in a minute. Well, if I were the benevolent overlord, if I were the CMIO in charge of everything, I would just make all the decisions, okay? Trouble is, clinicians look at the computer and say, this machine thinks it knows more than I do, but I'm the clinician. So what it says at the bottom, in case you can't read it, is I think you have that computer programmed to disagree with me. So that's why I say the CMIO needs to be in the middle of all of this. And I've pretty much mentioned this already, so I won't dwell on this, but as you can see in the periphery of this spoken wheel diagram, it really, the job of the CMIO intersects with lots of other organizations within the hospital at all levels. And don't forget your pharmacists and nurses. Please don't forget the role of your allied health professionals as well. And again, if I were the benevolent overlord, I would always make the decisions. If you want a second opinion, I'll just ask my computer, says the cartoon. So what could go wrong? Silos develop. If you have one committee always acting on its own without communicating with anybody else, nobody knows what's going on. That's a breakdown in communication. Change management is critical. Do you have a day once a week or once every 2 weeks when you're actually going to change the elements or the configurations within the electronic record so that you communicate that to all users so nobody is surprised? If you don't have something like that, your change management is not intact. What happens after that? People figure out workarounds, which are often poor, even dangerous. And keep in mind that one definition of a workaround is people figure out what to do when the system itself is broken. So people find a way around it. So if you find that people are using workarounds, your first assumption should be, well, we've done something wrong. We haven't followed workflow, and we're encouraging people to do the wrong thing. That intersects with accountability. If you acknowledge that you've made a mistake and you communicate with your clinicians and everybody else that you're going to fix something, well, do it. And then get back to them and say, you did it. And avoid these conflicting and duplicative processes. Don't have one person responding one way to a decision alert and have a different process for somebody else. That's going to be confusing and dangerous. So those are some of the internal. This group right here are mostly internal problems. What about external causes? Hospitals are merging and acquiring others all the time. So electronic health records change. Believe me, I've been through 8 paper and electronic transitions, and this is a major, major problem for governance. Leadership retirement or people just moving on. I mentioned that in terms of turnover. Demographic changes. I mean, this happens all the time. Populations shift, and we have to consider the impact of any existing artificial intelligence or biases. I mentioned that before. If your demographic changes, is your AI still applicable to the population that you're analyzing? You've got to continually analyze this. I mentioned regulatory changes, appropriate use criteria. Well, those of you that have been involved in radiology might remember that first we had to have clinical decision support for advanced technologies such as CAT scans, MRIs, PET scans. And then they said, no, we're just going to delay that. No, we're going to move it up. No, we're going to delay it again. No, we're not going to do it at all. Well, I have no idea, frankly, where AUC, appropriate use criteria, sits right now. I think it's kind of on the back burner and nobody's going to do it, I think. But somebody more knowledgeable with the up-to-date regulations will have to tell me. I mean, this drives us nuts of not really knowing what we have to do. And then, of course, pandemics get in the way. And I have the reference here to Reeves et al., and in particular the senior author, Chris Longhurst out in University of California, San Diego, they turned around on a dime when that cruise ship came into San Diego Harbor way back in, I think, the end of January 2020. And it blew up their CDS governance tremendously. They had to make changes, daily, weekly, and they had to change what they just changed and then change it again. This article is a tour de force of how to blow up your governance but still have governance. It's a very good article. And then you have to be on the lookout for new technologies. CDS hooks, Smart on Fire, CQL, all kinds of third-party applications for CDS external to your electronic record and maybe external, and usually external to your organization. These are on the horizon, was what I was about to say, but they're really currently now available. They're coming. I think these should be part of clinical decision support governance now, rather than to be a separate project. Otherwise, you're going to develop silos. All right, so everybody is familiar, I think, with Jerry Osheroff and colleagues' CDS that follows the 5 rights. Some of my colleagues and I kind of adjusted it a little bit, so I couldn't think of a better abbreviation than AWEEP. It's terrible as it is, but actionable. I mentioned how important that is before. Consistent with the workflow. In other words, it occurs at the decision point without any extra interruptions. It should be as easy as possible with the fewest number of clicks. People called me a click counter, and for good reason. Evidence-based, I've mentioned, and pertinent to the individual user. For example, a cardiologist doesn't really need an alert that says, hey, be careful if you're prescribing amiodarone. And for those of you not clinicians, those 2 drugs are excellent for patients with a condition called atrial fibrillation, and they're used together often, but there are considerable interactions between those 2 drugs. They know that. But what if someone's not a cardiologist who doesn't prescribe these drugs regularly and starts warfarin because of, say, a blood clot in the setting of a patient taking amiodarone? Well, maybe that person ought to be alerted that, hey, there's a problem here, and here's how you take care of it. So specific patient data based on specific individual clinicians' general state of knowledge and the evidence to make an alert actionable. So it includes all of these 5 rights. All right, so what did I just talk about? I think these governance principles apply to all healthcare institutions of whatever size. Now, by healthcare institutions, I'm mentioning not just hospitals, but office practices, nursing homes, rehab facilities, outpatient surgical areas. Anybody that deals with the health of individuals will have some form of clinical decision support, I hope, and that should come under governance, all of them within the constraints of budget, personnel, availability of resources, and expertise. My experience is that this kind of governance evolves. I don't have any empiric evidence for that statement, but every place I've been, the governance changes. Some of it's due to leadership changes, but a lot of it's due to, hey, that didn't work. Let's try something different. That means you have to be flexible, especially during pandemics. I mentioned that a minute ago. You have to have foresight. I think one of the jobs of a CMIO is to be thinking 6 months, 12 months ahead. What's coming down the pike? I mentioned especially for new technologies. So your governance has to reflect what you expect to happen in the near future. And it's hard, but I think it's mandatory. So thank you. I'm happy to answer questions. I see there's at least 2 things in the chat. So I'll open that up. And
I think you already addressed, they've already been addressed, but yeah, feel free to unmute yourself. I think we know most people here, or enter your comments or questions in the chat. Thanks for the excellent presentation. You know, we don't think about governance, right? We don't think about it that much. It's sort of there, and you sort of take it for granted. And it's either going to be the bad bandit or the good sheriff, as you put it. And I think people tend to think that's not relevant to their daily life, just trying to see patients or get things done in the hospital. And also, thanks for highlighting that. That's a cliche, right? Or the adage that informatics problems are people problems, and that time and time again, we think that we can fix it through fixing technology, but it ends up being about the people. So thanks for highlighting that. And also based on all your many years of experience. You mentioned some of the challenges, and for example, when you wanted to recruit somebody and they just wanted to go away, and because they're thinking, well, why bother? I don't like this. What's in it for me, kind of thing. Like, yes, they have all the pressure for compensation and everything. Any steps or advice on how to recruit those people that could help, including the naysayers, and the critical, thoughtful people, but they're so busy with their practice, and how to make it worthwhile so that they don't think that they're going to be spending even more time with pajama time.
Yeah. I think the short answer to your question is no, I don't think I have great advice, but the things that occurred to me are, of course, a good pay package. I mean, are we going to compete with the Silicon Valley and San Francisco area? No, not in the Harrisburg area, but it's got to be reasonable based on the local cost of living. That's one factor. The other is making your technical and clinical environment inviting and participatory, and department basically pats you on the back of the hand and says, they're there, I know better than you, you're probably not going to be able to attract or keep them. The other, of course, is a lot of people make their moves based on their families, their lifestyle that they want, the part of the country that they want to live in. You have very little control over that, but you can make it as inviting as possible. Just as an example, I've been in a hospital for 30 years. I was pretty much in charge of the education for medical students, residents when we had them, and especially advanced practitioners. And we would have a bunch of students come in from about 8 different schools in the relative area of ours, from Washington, D.C., Philadelphia, the Erie area where there's a large medical school. And we would attract those students to our institution because we gave them good teaching and good experiences with lots of hands-on, and they stay. Those PAs that you've trained that like you and you like them and they're competent, they're likely to stay. So having a good educational program, which is obvious to an academic medical center, I mean, that's what you do, like UAB, is going to attract people to stay there. It's very much more difficult for a community hospital to do that. But what I'm saying is, I think one of the responsibilities of community hospitals, like academic medical centers, is to educate. And that's going to recruit people, both analysts, but more importantly, I think students, PAs, CRNPs, and ultimately physicians.
Questions? We still have a few minutes. I have another question. How does, like we've been involved with a lot of efforts to allow people to have access to clinical data for doing research, but often the biggest challenge and issue is once again governance. Who has access to what data, and how are we going to do it, and the IT issues. So, any thoughts, intersection your work with governance with research?
Very interesting question that you're asking, because I'm involved in studying how institutions handle the governance and the ethics of their third-party data sharing. This is a very complex area, as it turns out. Research per se that is shared, say, with a pharmaceutical company because you're studying a drug, obviously you need to protect patients' privacy and security, and a lot of that, of course, is handled by HIPAA and other regulations. But one should also be mindful that if it's not a research study or not done by an IRB, for example, for machine learning or artificial intelligence, have you protected your patient's privacy and security, which are very much central, in my view, to EHR governance. Not so much CDS governance, I think, but security and privacy governance, which is a much larger and complex problem. I don't know all the ins and outs of that, but I served on a privacy and security group during my CMIO time with Geisinger. And I think that requires its own separate governance. So it's not a direct answer to your question, Amy, but it overlaps in the sense that good governance in CDS and good governance in privacy and security, in my estimation, really you're talking the same things. The same principles is how I would put it.
Yeah, thanks. You're right. There is external and pharmaceutical companies and such. I was thinking more internally and collaborators and things like that. But yeah, you're right. It's the same issues that come up. So I know that from talking to other CMIOs that, maybe it's different now, now that we have more infrastructure, more EHRs and standard terminologies and such, but that the focus is on operational. I just want to, we just want to make the thing functional and research. Well, that's just a nice side effect that I assume that we collect this data and it should be good for research, and that's somebody else's problem. Maybe that's different now that, and you're at a community hospital, but it's part of a larger network. So, depending on where you are, there's also going to be different priorities. I guess in a big academic medical center, having that research is maybe more important to their mission and their operations. But yeah, so just maybe just kind of like the operations versus research. But you touched on how that all operates within the governance.
Yeah, good points. Good points. Operational. My focus as a CMIO has always been more operational than it has been employment, for example, budget funding. I mean, as a CMIO, I reported up my scale, but I had exactly 0 reports and 0 budget the entire time I've been a CMIO at all organizations that I've worked at, which is not typical, certainly not typical for an academic medical center, but that allowed me to be operationally focused, which is good. As a community hospital within a larger academic medical practice, both Geisinger and Penn State, of course, are large academic medical institutions with smaller community hospitals. I think they can work together. It's been pretty amazing. I have to pat myself on the back how much research Holy Spirit Hospital has been doing over the last 30 years. I was also chair for 17 years of our local institutional review board before Geisinger purchased Holy Spirit Hospital. And we had 40, 50, or 60 ongoing research projects within Holy Spirit Hospital at any one time, mostly oncologic and cardiology, because we had a couple of researchers that were really into it. But it's amazing how much a community hospital can contribute to a larger academic research effort. Now, obviously, the quaternary university hospital is going to attract the super sick, the super complex patient with the unusual conditions that don't belong being treated in a community hospital. But those are complementary, not exclusionary. And that kind of governance to allow for that cross feeding, that cross interaction, I think is very important for an academic medical center to recognize the contributions that a community hospital can make and not underrate them or poo-poo it. I've seen that happen. I'm not Geisinger, not Penn State, but I've seen it in talking with lots of my colleagues in the CMIO world. The community hospitals just sort of discarded as, they're there, we know what we're doing, go behave yourselves or something like that. It's not a good concept. And the EHR can be the focus of that, and informatics can help coordinate those two. So I'll get off the soapbox now, but that's one way I've been able to do research as well as informatics and clinical medicine, as well as teaching. I combine all of those two together and doing it from the focus of a community hospital. It's been very satisfying in my career.
Yeah, I'm familiar with your work. It seems like even though it's officially research, it seems like at the time you're just like, I'm just trying to solve these problems and find out what's going on and how to help other people. Other questions? We're sort of getting to the end here. We have 2 minutes left, and you can always email. You can always send an email question. But since we have him here, virtual/live. Well, I wonder how is retirement going? I know it's only been a couple months, so it's early days, and also what your plans are, and what advice you would have for people who are planning such a transition too.
Well, thank you.
In 2 minutes.
Yeah, in 2 minutes. I won't belabor it. First of all, thank you everybody for participating. I saw there were quite a few participants, and I certainly enjoy discussing my work and your participation. Don't wait too long. I mean, I'm sure all of you have other interests besides informatics or clinical medicine or whatever it is that you do. And that was the case for me too. I've got 2 grandsons now, and spending time with them is very important to me. And certainly the life lesson, as my wife has often said to me, is I don't want you to work until the day before you die, because that doesn't make for a very satisfying retirement.